Getting this show on the road, we are moving on to Chapter 19, Endocrine and Hematologic Emergencies. The endocrine system is super, super important. It is responsible for a lot of bodily function. It works with just about every single cell or organ inside of our entire body. Endocrine disorders at that point can have many signs and symptoms, things you would expect and things that you wouldn't expect. The endocrine system, the pancreas itself, has functions in controlling blood sugar. It also has what's called exocrine functions, which aid in digestion. So the endocrine system really plays a role in just about everything. The main endocrine disorder we're going to talk about today, and where we'll spend most of our time, is talking about diabetes. Hematologic emergencies, it says difficult to assess and treat. Let's call it what it is, next to impossible to assess and or treat. We are treating signs and symptoms at that point. If our patient has hemophilia, which is a problem with blood clotting, even just something as insignificant as a little bump can cause them to have a pretty significant internal hemorrhage that is going to cause them a lot of problems, both with circulation, sensation, and motor function distal to wherever that injury happened to occur, but also with blood loss. Our patient is going to be able to tell us a lot about their condition when they have a hematologic problem. Even something like sickle cell disease. Sickle cell disease is a problem with misshaping of the red blood cells. Red blood cells generally have that sort of like almost donut looking appearance to them, but they don't have a hole in the middle. And they are shaped that way to give them, again, increased surface area and ability to carry oxygen around. When someone has the sickle cell trait, those red blood cells are no longer that nice sort of squished spherical shape. They are actually sort of crescent moon shaped. And a lot of the problems we'll see with patients who have a sickle cell crisis are those half moon shapes don't pass through a lot of the smaller vasculature quite as readily as they would if they were correctly shaped. So what'll happen is they'll start to jam up and pile up, and a blood clot will begin to form, and we can see hypoperfusion of tissues. We'll see a very, very large increased amount of pain with no reported injury. And it's going to be one of those times where oxygenation is going to be really important, because if our patient is in the middle of a sickle cell crisis, oxygen delivery is going to be a bit of an issue. And we want to make sure that our patient is ventilating and oxygenating well enough, because depending on where those cyclical shaped red blood cells wind up and that clog forms is going to depend on how sick this patient gets. If we have entire paths of our pulmonary arteries or the arterioles that are on their way to those capillary beds around the alveoli that are clogged with these cyclical shaped red blood cells, well, oxygen transfer is not going to happen from any of those alveoli. All of that blood's not getting there and not getting perfused, and we're going to see some hypoxia in our patient. We'll have very, very sharp chest pain. But what do you think our most significant finding with a lot of these hematologic emergencies are? They're not really going to be physical. I can tell you that. Where are we going to get most of our information? What's the most important thing we're going to hear? Think easy on this one, guys. My patient's going to tell me something, and what's that something going to be?
Having a hard time breathing.
I'm having a hard time breathing? Sure. One of the other big ticket items that they're going to say to me is,
My chest hurts.
my chest hurts. Yeah, they're okay. They're going to give me some symptoms. But the big thing that's going to push me towards that they may be having a hematologic emergency, since I'm already going to go right out on a limb here and say it's next to impossible to figure out on our own, is
High blood pressure.
how about I have sickle cell disease,
Mm.
or I am a hemophiliac,
Oh.
right? That's the most important piece that I am going to get from this entire assessment. All the rest of it is figuring out the signs and symptoms associated with, figuring out how well is this patient doing by monitoring their vital signs, ensuring that I have an open, clear, and secure airway, ensuring that my patient is breathing at an adequate rate, rhythm, and quality, ensuring that my patient is got an adequate rate, rhythm, and quality of their pulse and they're circulating blood well enough, and maintaining a mental status by talking to this patient and transporting them. Because other than that, there is not one blasted thing I can do to even help them with their hematology emergency, other than ensure that they are in as good a condition when I leave them as they were when I found them. Endocrine is a bit different. Endocrine we can have some effect on. The endocrine system is hormones. The endocrine glands will secrete hormones into the bloodstream, and those hormones will cause a reaction somewhere else in the body. The main problem we're going to talk about is diabetes, and the main problem with diabetes is the body's ability to metabolize glucose. The brain needs glucose and oxygen. Insulin is absolutely necessary for that insulin to get inside the cell to create that energy. The sugar molecule itself, when paired next to a cell, sugar molecule is really big, the cell is really little. Something needs to facilitate that sugar getting into the cell. Insulin is that something. Insulin is the key that opens up the door that lets that glucose molecule go in, and then energy is created. When we have a patient who's a diabetic, their pancreas either doesn't produce any insulin, so it stopped working altogether, or it doesn't produce enough, or the body just doesn't use it effectively enough. When insulin isn't in adequate supply, the cells are going to think that they're starved for sugar. Regardless of how much sugar is actually in this patient's blood, the cells are going to think that they don't have any, that they can't use it, because they can't use it because the sugar can't get in. So then metabolism doesn't happen. If aerobic metabolism isn't happening, these cells are all going to switch to anaerobic metabolism, not to mention the fact that they're sending off messages to the brain that's saying, hey, we're starving down here, we need more sugar, you need to eat something. So our diabetic patient is going to eat more, and it's going to produce more glucose in their bloodstream. But what still isn't going to happen?
Still not going to absorb into the body.
Yeah, it's still not going to absorb into the cells because there's no insulin to let it in. And if there's no insulin to let it in, all that sugar in there just floats around inside the bloodstream and goes on to wreak havoc. Diabetes is what that impairment is. For whatever the cause is, we'll talk about type 1 diabetes, we'll talk about type 2 diabetes, but whatever is causing that impairment is really the pathophysiology of diabetes. The body's cells can't get that glucose in for fuel to create the aerobic metabolism, and blood sugar levels without treatment will just get higher and higher and higher and higher and higher. The higher your blood sugar gets, the sicker you become. And realistically, this turns into a life-threatening illness, coma, and death pretty quickly. This is generally in the beginning stages when diabetes is first being diagnosed. Once our patient is a known diabetic and they're prescribed some medication and they're receiving some treatment, we still see complications with hyperglycemia or high blood sugar. Years down the line, diabetes can cause blindness, diabetes can cause cardiovascular disease, hypertension, kidney failure, peripheral vascular disease, problems with patients' circulation, sensation, and motor function. And it's all because there was too much sugar in this patient's blood for too long of a time. And that big glucose molecule in high quantities does just go around and wreak havoc. The tiny little vasculature in your eyes becomes damaged. The tiny vasculature in your kidneys becomes damaged. Your eyes won't work as well. Your kidney function starts to fail. And it really just, since the endocrine system touches so many things, poorly controlled diabetes, which is generally what we're going to see, really can have negative impact and negative outcome to almost any portion of the body. We'll talk about the signs and symptoms of hyperglycemia versus the signs and symptoms of hypoglycemia. We'll talk about checking a patient's blood sugar. Hyper and hypoglycemia can occur in either type 1 or type 2 diabetes. There's no hard written rule that, oh, you're a type 1 diabetic, your blood sugar will never go high, it'll never go low. That's not the way this works. When we find hypoglycemia in the field, so we take our patient's blood sugar and we find a number that is below 70, it is imperative to treat that right away. Because if there's not enough sugar in the blood, what's the major organ that this is going to have the most impact on?
The brain.
The brain, because the brain is completely intolerant of that loss of sugar. So we'll see alterations, significant and severe alterations to our patient's mental status when we have hypoglycemia. Type 1 diabetes is an autoimmune disease. That means the immune system has decided that the pancreas, arguably one of the more important organs that we possess, is not self. And those antibodies that the immune system has now gathered around go off and kill the beta cells in our pancreas. Those beta cells are the only place in the body that insulin is produced. The pancreas is it. And once those beta cells are gone, the pancreas stops producing insulin altogether. They say onset is usually early childhood through the 4th decade of life. Really, it can happen just about any time. If your patient is a type 1 diabetic, they have to get insulin from some form of external source. It could be injections, it could be what we're going to talk about right now, or an implanted insulin pump. This is how I actually manage my insulin, my blood sugar, and control my diabetes. I have 2 things that are implanted into me with a needle every couple of days. And it will continually measure my glucose and adjust the amount of insulin that it gives me. And in doing so, it keeps my blood sugar pretty regular. Part of our focused exam for a patient who is unresponsive with a low blood sugar should be to look around and see if we see anything that is implanted in this patient that makes us think possibly it is a insulin pump. Because if my patient is unresponsive on the floor and I find an insulin pump, insulin controls your blood sugar. Insulin will bring your actual level of sugar in your blood down. So if my patient's unresponsive from low blood sugar, I take their blood sugar, it's 58, and they're on the floor unresponsive. Is their insulin pump helping them right now?
Clearly not, no.
Yeah, no, it absolutely is not. It's actually killing them. So there are as many ways to remove an insulin pump from a person as there are insulin pumps available on the market. So worst case scenario, you find the place that it connects to the body and you disconnect it from the body. Don't go pushing buttons. It would be, I can tell you, as having had several different kinds of insulin pumps, it would be next to impossible for you to accidentally give me insulin by just pressing a button. But Don't go pressing around with stuff. Worst case scenario, pull it out. I'll show you guys when you get here, sort of the stuff that I have connected to me, and we'll talk about how you can get them off of your patient in a pinch. So, most common metabolic disease of childhood. Most of the time, our childhood is generally fairly healthy. Excuse me. Diabetes is not generally diagnosed with low blood sugar. Diabetes, the pancreas just stops working, especially type 1, it just quits. So normally when a person is diabetic and diagnosed with diabetes, it's because their sugar climbs to this outrageous level. Now, we start treating below 70. If a patient is below 70 and symptomatic, we're going to give them oral glucose. Depending on which book you read, 70 to 110, 80 to 120 is the blood sugar number that we're looking for. Those are what's considered, quote, normal. When I was diagnosed, my blood sugar was 1,084. And that is how most diabetics are diagnosed. Some of the symptoms that may be reported to you by either the patient or their family is polyuria, polydipsia, polyphagia. So polyuria means that they are peeing a lot, like all the time. They are in the bathroom nonstop. Polydipsia means that since they're peeing all the time, they're drinking all the time. So they are just perpetuating this negative cycle of constantly peeing out all their electrolytes, trying to get rid of all this excess sugar, and then drinking a ton of fluid to replace it. And polyphagia is that constant hunger. That is that message being sent off by the cells saying, hey, I'm hungry, feed me. Hey, I'm hungry, feed me. Hey, I'm hungry, feed me. And no matter how much they eat, they are losing weight like it's going out of style. Again, speaking back to things that I know personally, I lost 55 pounds in a weekend when I initially was sick, and nobody had any idea. I had the flu.
Did you just say 55?
Yeah, 55. My blood sugar was so high that all of the eating, all of the drinking, all of the peeing was just, my body was eating itself because it switched to that anaerobic metabolism, and all the constant fluid loss and all the constant electrolyte loss, you wind up with profound dehydration. So these people are dry as a bone. They are hot to the touch, and you wind up looking like, like one of those malnutrition commercials. It's insane when you see somebody that's in this shape, and it happens so quickly that there's like no time to do anything about it. And then you have that constant fatigue for the period of time that it takes all of these things to be figured out, because your body's not creating any energy effectively, any portion of your body. The later stages of all of this, like ridiculously high blood sugar, will turn into things like changes in your respiratory pattern. Now your respiratory pattern changes in order to try and breathe off some of the acidic nature of your blood, because your body has turned to burning fat as its form of energy. So you wind up burning fat and producing ketones. Ketones is that acidic byproduct from all of that acidic waste product of cellular anaerobic metabolism. Kidneys eventually don't have the ability to filter out enough of that acid, and that acid starts to build up in your bloodstream and build up and build up and build up, and you can't get rid of it fast enough because every single cell in your body is starved for the sugar that it needs to create the energy that it wants to keep all of this machine going. And that increase in glucose just triggers you to eat more because it can't get into the cells. and more waste product is generated and more sugar winds up in the blood. And once we've been in that for long enough, that ketone production will develop into diabetic ketoacidosis. Diabetic ketoacidosis is a blood sugar of over 400 at least. You may do a blood glucose check on your patient to try and figure out how high their blood sugar is. And the machine may come back and tell you high, just the two letters, HI. And what that means is, depending on the manufacturer of your glucometer, your patient's blood sugar is either over 500 milligrams per deciliter or over 600 milligrams per deciliter. Now keep in mind that normal is 70 to 110, 80 to 120, somewhere in there. And you can start to see why so much of this patient is affected, and so much of it may present as just generalized illness. Your patient who's in ketoacidosis may have complaints of abdominal pain, achiness, nausea, vomiting. All pretty innocent sounding stuff, right? Maybe
Yeah.
they become.
Question, Tom. Then, I mean, it should definitely be considered protocol of part of a whole assessment. It should be always, you think, in your opinion, to always check a glucose level.
So I don't want to say always, because for a while glucometry was one of those things like, oh, everybody got a sugar checked, and with some people it's not warranted. With some people, your diabetic patients, yes, always check a sugar. If your patient is altered, yes, always check a sugar. But one of the big hallmark things we're going to see with a patient, and one of the things that's going to point me towards I should check this patient's sugar, is when your patient is producing a lot of these ketones. One of the things that happens pretty well right away is you'll smell like a sweet, sugary, almost a mix between like Kool-Aid and nail polish remover smell to their breath. And that right away should trigger you to say, like, all right, we need to check this patient's sugar like right this very minute. Because that is one of the big things. And if you couple that with our polyuria, our polydipsia, our polyphagia, there's not a lot of things that are going to cause those three symptoms altogether. You know, polydipsia, somebody's thirsty and increasing the amount of fluid that they're taking in. Okay, well, have they increased the amount of energy they've expended? Have they increased, a workout routine or something like that? That's pretty simple. But if you start to say, well, I've been peeing a lot and I've been drinking a lot and I'm constantly like insatiably hungry, that should right away start to be like, all right, we definitely want to get a look at endocrine and metabolically sort of what's going on with this patient. Especially if we can start adding into that now something we can point to and say, oh, all that acid's building up in their system. And it'll take me 10 seconds to figure out, is my patient's blood sugar ridiculously like rock star kind of high? So I don't want to say take everyone's blood sugar, but if you start seeing things and hearing things that are telling you, or smelling things because that fruity smell of their breath is like dead giveaway. But if they start to really, paint the picture for you that we have some form of endocrine problem here, it only takes a couple of seconds to figure out, do we have an endocrine problem here or not? And a blood sugar is going to do that. So that was our type 1 diabetic. Our type 2 diabetic comes in a couple of different flavors. Our type 2 diabetic is either someone who doesn't produce enough insulin, their body doesn't use that insulin effectively enough, or they just eat too many calories and their pancreas can't keep up. Obesity is going to show an increased resistance to insulin. So that means the body's not keeping up with intake, and demand is the problem here. Somebody intakes too much and they're demanding too much of their pancreas, and the insulin just can't keep up with it. Over time, we'll start to see type 2 diabetes develop in elderly people because everything's born with a shelf life, even your pancreas. You may not be able to live to the ripe old age of 105 and still have a normally functioning pancreas that just continues to produce insulin for you. Dietary changes, taking better care of yourself are things that we can control when we start talking about type 2 diabetes. Things like family history, because there is a bit of a genetic link to it, are things that our patient can't control. If our patient can't adequately control their diabetes on their own, they have some options. Type 2 diabetes used to be called non-insulin dependent diabetes. They don't call it that anymore because every once in a while they do use insulin in the short term anyway to try and control blood sugar. They do take a lot of oral medicines. They have oral medications that can sort of ramp up the production and increase the secretion of insulin. They have other other oral medications that they can take that will just attempt to decrease the amount of glucose that's stored in the liver and the amount of sugar that is released by the liver. They also have other types of injectable medicines that aren't really necessarily insulin that will help them to maintain their blood sugar. So now let's talk some symptoms of hyperglycemia, because hyperglycemia doesn't really get super symptomatic until late in the game. Symptomatic hyperglycemia is really, really significant. It means the blood sugar is actually really particularly high. If we have an alteration to our patient's mental status and we have a diabetic history and family history that's telling us the HPI, right? So the history of our present illness is telling us patient's been eating a lot, patient's been drinking a lot, can't pass a bathroom without going in for a pee. That's telling me that my patient's probably acidotic. They probably have this diabetic ketoacidosis going, and I'm going to confirm that with a blood sugar. And what do you think I do next? We'll say I've gotten to the end of my assessment. Is there anything I can do to treat this?
No.
Absolutely not. Insulin is probably one of the most dangerous medicines you could ever be next to. It is entirely easy to accidentally kill someone with too much insulin, and it is not something that even places like Boston MedFlight will initiate and transport. They will give blood, but they won't start an insulin drip. So it is a significant, significant medication. So what's my treatment priority here? What am I going to do?
Transport, contact ALS.
All right, keep going.
High flow O2, question mark.
All right, keep going. Come on, Pat. I know you got some more in you. Keep going.
I'm not sure. Advil or no, that's all I could think of.
So what's some stuff that we've covered in assessment and treatment so far? You were right on with transport, contact ALS, and get some oxygen on board. I liked all of that. Where are we going to concentrate our efforts?
Constant reassessment.
Constant reassessment, going right back to mental status, level of consciousness, going right back to airway, breathing, circulation. Because with somebody who is symptomatic and hyperglycemic and sick enough that I'm worried about all this, now let's just call it what it is, right? All this acid-based stuff and all this diabetic ketoacidosis and all that big fancy things. Not a thing I can do to fix it at this point, not one. But what I can do is make sure that my patient, if they had a mental status to begin with, I can try and maintain that as best as possible by constantly jabbering at this patient and making them talk to me, which also tells me my patient's airway is remaining patent, which also gives me a pretty decent look at breathing, rate, rhythm, and quality. If they have an on-breather mask on, I'm doing something to support oxygenation. I'm also going to check rate, rhythm, and quality of their pulse, skin color, temperature, condition. I don't expect a lot of these things to be great, but I have to keep going back there because sooner rather than later, this patient could become so sick that you may need to manage their airway. This patient could become so sick that you may need to manage their ventilation. This patient could become so sick that they go into cardiac arrest, and we're off and running. We're working a cardiac arrest. So this next thing we're going to talk about, I can almost never say this whole bit without screwing it up. Hyperosmolar, hyperglycemic, non-ketotic syndrome. This is our type 2 diabetic. So our type 1 diabetic is the one that we're looking for diabetic ketoacidosis, that constant urination, constant drinking, constant eating. This hyperosmolar, hyperglycemic, non-ketotic syndrome is a type 2 diabetic. And some of the key things we're on the lookout for here is this is someone whose blood sugar is really, really high. They may have that crazy hyperglycemia. They may have severe thirst and urination, but they don't smell funny. Their blood sugar is going to be just as high. The problems are going to all be the same, but this is generally a type 2 diabetic whose body just isn't producing insulin quite effectively enough. If we have a type 1 diabetic and they eat, their blood sugar just goes up because there's no insulin to do anything about that. We have a type 2 diabetic whose pancreas still works a little and its body is still using some of the insulin. It just can't keep up with demand. They eat and their blood sugar goes up, but then their pancreas kicks in a little. But we never get right back down to where we started. And then they eat and their blood sugar goes up. And they eat and their blood sugar goes up. But their pancreas kicks in a little, but we can never get down to that 70 number again. We can never get back down to normal. Whereas your patient whose insulin is totally not being secreted, totally not being generated, their numbers just go up exponential. They just continue to climb. So when we're getting our history of the present illness and we're talking to the patient and talking to their family, does that sound like it takes a little while to develop? So we're at O in our secondary assessment. We're getting our onset. Does higher blood sugar sound like it takes a while to actually come about?
Yeah.
All right. There's one of your key assessment differences. Hyperglycemia is a patient who reports not feeling well over time. Hypoglycemia,
It's going to start immediately.
just about. Hypoglycemia is an acute emergency. Glucose levels drop quickly, need to be fixed quickly. This can happen for any one of a number of reasons. Patient took too much insulin or too much medicine by mistake. There's times where I've been running around and not paying attention to what I was doing. I took my insulin for what I was gonna eat, then get called away and didn't get a chance to eat, so my blood sugar starts to sink like a stone. Someone who takes their insulin and then doesn't feel well and decides not to eat, well, I took the medicine, but I didn't input any sugar. So your patient who's got hypoglycemia and is symptomatic, it generally doesn't take that long amount of time to develop. It's normally pretty quick that they become symptomatic.
That's due to the brain not being able to not have enough glucose, but when it does, it doesn't really matter as much when it starts increasing a little bit.
Right. When it goes up a little bit, and it goes up a little bit each time, it takes a lot longer for the blood sugar to get high because it goes up some insulin gets secreted, and we might go back down a little bit or at least stay the same. And then I'm going to eat again, and it goes up some more. And this can take a period of hours, days, a week. There's no real time frame, right? Because you don't know how much insulin the pancreas is actually secreting with each meal and with each bout of increased blood sugar. But with our symptomatic hypoglycemia patient, our onset is normally different. Our onset of that low blood sugar is generally almost immediate because the brain won't tolerate that hypoglycemia. So we'll start to see a pretty sudden drop in our patient's mental status. Our patient may really start to exhibit some unusual behavior. I normally say that, when you show up and your patient's a symptomatic hypoglycemia, you'll look around and everybody in the house will be mad at them, and they'll be in the living room barking like a chicken. It's crazy. The brain just does not function. Sooner rather than later, your symptomatic hypoglycemic patient will run out of sugar altogether and become unresponsive. Hypoglycemia develops fast. Hyperglycemia develops slow. They have a lot of the same presentation other than that. Other than the number and the sudden onset of hypoglycemia, the two conditions really look very, very similar. Hypoglycemia is just weird because you could have somebody, I told you guys that the machine will read high, HI, if a blood sugar is above 500 or 600. If a blood sugar is below 20, it'll read low. There have been times where I have driven home from work with a blood sugar that registered low on my glucometer when I got home. There have also been times where I have had a blood sugar of only like 68 and been ridiculously symptomatic. So there's no rhyme or reason as to why the brain is so fidgety and so fussy depending on what the blood sugar is. That's why we treat it 70, because the book's telling me right here, 80 to 120 is normal. We're going to start treating it 70 because we know 70 is generally when symptoms begin to develop. At 40, we are technically in a hypoglycemic crisis. That means this patient could be unresponsive at any time, period. They could just lapse into unresponsiveness and no longer be able to maintain their airway, no longer be able to follow our instructions, and we would no longer be able to give them the oral glucose that is going to help them. Our scene size up is going to be important. I will say this patients with diabetes may use syringes. What I can say is I've never seen a diabetic throwing used syringes on the ground outside. Most diabetics are pretty conscientious about taking care of their needles appropriately so people don't accidentally get stuck. But it is possible. Know that there will be sharps on scene. Be alert for clues. Talk to the family. Use standard precautions. Know that a symptomatic hypoglycemic patient may be all kinds of nasty. But sooner or later, that's going to stop because they're going to go unresponsive. There's no sense in fighting with these people. If your patient is so out of control that scene safety is a hazard, scene safety is a hazard, and don't be involved with it. Sooner or later, the patient's going to go unresponsive. I speak from experience. I know that there have been times where my blood sugar has been particularly low, and I have just been an outright jerk. It happens, and it's weird. So take care of yourselves. Talk to bystanders, talk to the patient, keep an open mind as to what may or may not be going on here. It may not just be a diabetic emergency. We have to rule out the regular sort of causes of our altered mental status, and checking this patient's sugar is going to help us rule in and rule out what the most likely primary cause of this problem is. Always going to start with our primary assessment: airway, breathing, and circulation. Airways need to be open, clear, and secure to be called patent. If my patient is unresponsive, is his airway patent?
If he's unresponsive,
Yep.
no.
Good. If he's unresponsive and his airway's not patent, I need to do something to make sure that it stays patent. If he's responsive and talking to me, even if he's in the living room barking like a chicken and acting like a jerk, I at least know that the airway is patent with every cluck. From there, we move on to breathing, rate, rhythm, and quality. One of the things that we're going to add to our breathing assessment is if we think it is a hyperglycemic emergency, if we think hyperglycemia is the cause of my patient's altered mental status, when they're breathing, watch their rhythm, watch their rate. When they're breathing, see if you can get any weird smell coming off of their breathing, because that is really going to tell me, is my patient's blood sugar high? Hypoglycemia doesn't have a whole ton of effect on respiratory rate, rhythm, and quality, but if we find any signs of respiratory distress, we manage those. We apply oxygen or we ventilate the patient. Circulatory status is going to tell me a lot of stuff here too. Dry, warm skin generally points me towards hyperglycemia. Why do you think that might be?
Take a shot. Their body's working at a higher rate.
The body is working at a higher rate, but if my blood sugar is really
It's got plenty of glucose in it, and
it does
oxygen.
indeed. Think about this for a minute. If my blood sugar is really high, I'm spending all my time in the bathroom and peeing out all of that fluid, all of those electrolytes, all of that plasma is sort of going by the wayside. So my skin's going to be dry because I'm actually dehydrated. No matter how much I drink to try and replace all that fluid I'm peeing out, it does me no good. So your hyperglycemia, their skin color temperature condition assessment is going to be really important. Your hypoglycemia, your skin color temperature condition is going to be really important, because my hypoglycemia patient is going to be moist, pale skin, sweating like a dog, and pale, maybe even cool to the touch, because the body's under attack here. And you know what it does? It releases a whole bunch of epinephrine. That's why a lot of times your diabetic patient who is acting in an aggressive fashion and behaving like a crazy person has the strength of 10 people, because they have enough epi running through them to power a small city. So scene safety is a consideration for our diabetic patient who's also having a bit of a behavioral issue. But look at your skin color temperature condition. It tells you things all the time. You can start putting these pieces together and getting down to what it is that's going on here. And that is Endocrine Emergencies. What do you guys think? That wasn't too awful miserable, was it?
No, that one was pretty. It's not a whole lot we can do for either of them.
Right. High blood sugar is nothing. Even really at the ALS level, all they're doing at the ALS level is they're going to try and cut some of that high sugar content by adding fluid. So they're not really lowering the sugar because there's still every bit as much sugar in there. They're just trying to dilute it.
Yeah.
All right, we got behavioral emergencies left. We're going to take another break because, Christ, I've been at it for another hour. I can't shut up today, can I? So I have 11:01. Why don't we say 11:13? We're going to come back and we'll finish off our lecture for today and we'll be all caught up.
Sounds good.
All right, here we go. Everybody back from break. We're ready to move on to chapter 22, Psychiatric Emergencies. So in the pre-hospital environment, oftentimes we are going to be dispatched for behavioral crisis, psychiatric emergencies. Could be the result of an innumerable amount of things. Could be trauma, could be an acute medical situation, things like hypoxia or sugar problems. Could be cardiac in nature, could be a stroke developing that's making your patient act the way that they're acting. It could be use of drugs or alcohol. It could be stress. It is really, really important to just not jump to, all right, this behavioral, this psych emergency is at the root of it all, psych. Some point or another, people wind up with some form of emotional, they call it an emotional crisis. It doesn't have to be something that is completely life altering. It doesn't have to really be, what you would maybe consider something that would push you to the edge of being able to maintain. Go with an open mind. Doesn't always mean that the patient is sick. Doesn't always mean that there's something wrong with the patient. Sometimes it does, sometimes it doesn't. And the book is really good about this portion of it, talking about there are justifiable reasons for people to be upset. There are justifiable reasons for those things that are upsetting this person to actually cause them to have some form of crisis. Think about big ticket items that would be upsetting for you or anybody else. Divorce or loss of a significant relationship, loss of a job, death of a friend or a family member or someone that you're close to. And it doesn't take long for those kind of things to stack up and eventually be the last straw that sends somebody into a depressive state or has them have some form of break with reality and send them into crisis and need our assistance as emergency service providers.
Yeah, Tom, are the slides changing?
Yeah, my slides aren't changing at all either.
Same here.
How's that?
Oh, perfect.
Yep.
Thank you.
All right. There wasn't much substance on any of those anyhow, so that's okay. Only a small percentage of behavioral emergency patients that we show up to are actually going to be violent, dangerous, unmanageable situations. Not many. We are a bit more exposed than other folks when it does come to managing a patient who is violent or dangerous, because we're in the back of the ambulance with them at most at any given time, 2 to 3 feet away from them. So rapport building is important for us. One of the good things that sort of we have going for us when we're going to load a patient into the ambulance is, for the most part, we can play the good guy role in highly charged situations where we're talking emotional, behavioral, psych type issues. Most of the time you get what you give, right? So treat these people with a little bit of respect, a little bit of, maybe extra niceness. Don't over the top, don't overdo it, because they'll see through that cloud of smoke. But we are really the good guys. Hey, listen, you're going to come to the emergency room. They'll take care of you. We'll get you away from this situation here, because there's going to be a lot of people. There's going to be probably quite a few unhappy people. We can be that, good cop and be the ones to, hey, we're taking you out of this situation. But never really put yourself in the wind, right? Never really say, they're not that dangerous. They're not that violent, because it's unpredictable. When we talk about violence, it is very difficult, especially when someone who is not behaving to the social norm and is having a behavioral or psychiatric emergency. The way you process things and the way they process things is going to be different. So sometimes violence is predictable, sometimes it isn't. If you go to somebody's house and you know that they're always a problem, today they're probably going to be a problem as well. But you still have to try and enter in playing that good cop mentality, whether you know at the end of this, you guys are going to wind up restraining this patient with PD and everybody's going to wind up on the floor and it turns into a miserable situation. Going in with that open line of communication and trying to de-escalate things and getting some form of level of trust, even though that maybe it's never going to happen, is the best way to approach these scenes and these situations. When we talk about behavior, behavior is just the way the patient responds to and interacts with their environment. Most of the time, we're looking at people's ability to respond to their environment and interact with the world around them, and it's reasonable and very, very normal. Even in stressful situations, people adapt to stress. People are able to cope and use sort of the chapter 2 stuff that we talked about, those coping mechanisms for us as emergency providers in workforce safety and wellness. Well, normal people use those too in order to cope with the stresses of daily living and daily events. It's just when those things begin to stack up that now we see a behavior turn into a behavioral crisis or a psychiatric emergency, because now their behavior has become outside of what is reasonable, outside of what the social norm is. Once those coping mechanisms start to fail, a couple of things will happen. Either the patient looks for things that are more negative ways to cope with their situation, when we talk about like self-medication with drugs and alcohol, or they find positive ways to cope with their stress and they seek out professional help and they're being evaluated and treated for that, or they just remove themselves from the stressful situation. But behavioral emergencies are a big contributor for us. It may involve patients that are agitated, violent, uncooperative. They may be a danger to themselves. Generally, we wind up at a scene when someone's behavior has risen to the point where it is now unacceptable to family, friends, and community. Patients a lot of the times don't call 911 on themselves during a behavioral or psychiatric crisis because they kind of have taken a bit of a break from reality at that point. Their behavior now has risen to the level that it is troubling people to see it, and they're just living it. Some of the book definition type stuff we have here is that if an abnormal behavior lasts for more than a month, it is clinically significant and constitutes a bit of a behavioral psychiatric emergency. Patients may react negatively to our presence because really, this is what they're doing. And especially if it's been going on for an extended period of time, their life has now adapted to the fact that they are in this crisis and have been in this crisis for quite some time. So our presence may not always be welcome. They may not believe the fact that they are having an issue and may not want any help. They may be a threat to themselves. They may be a threat to others. This is all going to be a lot of verbal judo, working with these patients and talking to these patients, because gaining that level of trust is going to be difficult. Tens of millions of people are affected by some form or another of mental health disorder each year in the United States alone. Some of the big ones that we'll talk about coming up are anxiety disorders, depression. We'll get into probably schizophrenia a little bit. Why is this becoming such a big problem and so grand on the scheme of issues that we see?
It's like today's social standards. Is that what you're going at?
Yeah. Why is it so widespread? Why is it so prevalent? I can think of a couple of reasons, really.
Yeah, there's like almost endless reasons you could come up with. You could talk about this for 3 hours.
Well, we don't have that kind of time, so come up with a couple and let's chat. One of the things I can think of is a lot of the problems we see in healthcare as a general rule, we can trace all the way back to funding. You know, there's not a lot of funding, not a lot of support for mental health. You know, what are the things that they cut from the budget, right? It's healthcare, and specifically it's more mental health, because you can't cut cardiology because everybody needs a heart, and everybody looks at, you know, mental health disorders as something people should be able to take care of on their own. And sometimes they can, sometimes they can't. The mental health system is great for people who can access it. It is great for people who choose to access it. Most of these disorders can be handled through outpatient visits. Most of them are pretty well managed and people can go on with their activities of daily living. Some can't. Some people do require hospitalization in specialized psychiatric units. And you guys will see when you're out there riding around in the street that there's not a lot of room in those places. It takes a long time for a patient who's in the emergency room to wind up getting a bed in some of these places. And it's almost like a revolving door. It's, you know, in there for 3 days, back out on the street, you know, all right, here's your ability to follow up. But we just took somebody who was in the middle of a behavioral crisis. We put them in a unit for 72 hours, maybe a week. And then we get back out onto the street like a week later, and we're seeing the same people, the same problems, and the same solution. Off to the emergency room we go. It takes 3 days for them to find a bed. It takes another 3 days of evaluation. On the 7th day, they're back roaming around the streets of the city of Everett because nothing about their situation has changed. I wish I was smart enough to come up with the solution, and I'm not. But it is something that you guys are going to see moving forward as providers of emergency medicine, just based on the amount of people that we see day in and day out with these problems. Tens of millions of people every single year in the United States. Psychiatric disorders can have one laundry list of underlying causes. Social and situational, sure. Divorce and death. They could have a disease process underlying something like schizophrenia. I could have a behavioral emergency this afternoon if I don't eat my lunch. Diabetic emergencies, drug and alcohol dependencies, electrolyte imbalances, anything that affects the way that the brain functions and processes information. Then add to that most people that really have significant underlying psychiatric conditions don't feel sick. They don't actually feel physically sick. Schizophrenia is a great look at that. Bipolar disorder, same thing. You'll prescribe this patient medicine, and the patient starts to feel better. And then generally, what do?
Stop taking the medication.
They stop taking their medication, and they don't actually feel any physical difference in their person when they stop taking that medicine. And they don't notice the changes to their actual behaviors and see the things that they're doing that are falling outside of what the social norms are. And then they wind up in front of us again. And we wind up right back in the meat grinder doing the same thing over and over and over again. And it's just kind of, I always look at these kind of calls, and as much as I don't enjoy going on them, I don't think anybody does. I always look at these kind of calls as like, this to me is sadder than the person who's lived to a ripe old age and has a DNR and it goes into cardiac arrest. Because this person who, when they take their prescribed medicine, continues on their merry way, goes about their activities of daily living, goes about their normal routine, does all the things that a normal person does. And then one day their brain tells them, you feel better. You don't need to take that medicine anymore. Then they don't. And we watch the downward spiral. It's a vicious, vicious cycle of mental health. And it takes a lot of work for the patient. And it takes a lot of work for you guys as providers to sort of help this patient, especially because you look at it as, is this patient even helping themselves? I get it. I get it 100%. We're not really responsible for diagnosing what's going on with this behavioral crisis. Most of our psychiatric work is going to be in managing the patient. Is this patient likely to have problems with airway, breathing, or circulation? Is this patient likely to tell us anything during OPQRST and sample that make us really, really concerned for their ability to still be a physically healthy person throughout the rest of my assessment and transport to the hospital? The answer is probably not, right? They're probably not going to tell me anything of much clinical significance in a strictly medical fashion, which instantly makes this patient more difficult to manage because I handed you a 1,500-page textbook and we've talked at length now for almost 80 hours about diagnosing and managing and taking care of all of these medical conditions. Our job with a behavioral emergency, therefore, is light years more difficult than a patient who's got chest pain. All right, chest pain, I know I'm going to monitor my ABCs. I'm going to make my transport decision. I'm going to ask the OPQRST questions. I'm going to ask the sample questions. I'm going to get a set of baseline vital signs and mush all of those things together to give my patient aspirin, oxygen, and maybe some nitroglycerin. Then we're going to transport, and I'm going to drop this patient off at the CHA in Everett. I'm going to tell him to have a nice day, and I hope he feels better. And my job was just very, very simple. My life was easy at that moment in time. Now I'm in the back of the ambulance with somebody who's got some form of temporary brain dysfunction that is causing them to have some form of functional break with reality, but they're still able to carry on as a person. And I have to try and talk to this person and get this person who is yelling about the government listening to their thoughts and Apple microchipping everyone and get them to trust me and just go back and forth with me for a couple minutes while we are on our way to the hospital to get them checked out when they probably didn't even want to go to the hospital in the first place. So now I have to convince them to do something that they didn't want to. Always consider safety. Always give yourself an out. Use your standard precautions. Request additional resources early. Don't already be in a fight with this behavioral emergency patient and then start thinking, boy, I wish we had some cops here. Get out in front of things. Don't ever be behind any of the issues that you might see on scene or might be involved in on scene. Still, nothing has changed. We're looking at mechanism of injury and nature of illness. When we ask about medication and medication compliance, when we get down to sample after we finished off the rest of our primary assessment, these are things that are going to be important because let's say our patient did start to feel better and stopped taking their meds. Okay, well, how long has it been since you took them? Because over time, my patient's mental status is going to deteriorate as those meds that took time to build up in their system begin to leach their way out, and they go right back down to their baseline mental status of psychiatric emergency behavioral crisis. Our general impression always formed from the doorway anyway, but it's more important here. We're going to perform just a real rapid scan just to figure out how is this patient doing? I'll be able to get a little bit of perfusion. I'll be able to get a little bit of breathing. I'll be able to figure out airway because I'm going to start talking to this human. I'll get myself into airway, breathing, circulation, and we'll start discerning whether is this a medical, is this a psych, is this possibly a trauma and they're altered and acting crazy because somebody smashed their brains in with a bat. You know, all of these things have different priorities and different pieces that I'm going to need to look at before I just decide, all right, this is straight behavioral. Get the chief complaint from the patient. They may tell you something that you consider completely off the wall, and it may fall into a problem with one of these three areas. We could have a problem with the brain. We could have a problem with drugs or alcohol. We could have significant just issue for the patient. Talk to them, they'll talk to you. We're going to use like reflective listening. Reflective listening is a technique where they say something to you and then you kind of parrot it back to them in your own words so that way they know that you're paying attention. And the more that they think that you're paying attention and valuing what they have to say, the more things that they're going to say to you. And then it just continues on and on and on and on and on and on and on. Because at the end of the day, we really are trying to get this patient to do something that they probably don't want to do. If you ever sold used cars, now would be the time to brush off those salesmanship skills and kind of schmooze and talk with your behavioral emergency patient. But we're constantly assessing, is this definitely mental health? Are they answering appropriately? Does their behavior seem appropriate? Well, probably not. That's probably how you wound up in the living room. But is the patient understanding me? Is the patient even responding to me? Happy, sad, mad, hungry, whatever. Constantly, constantly, constantly monitor this patient to see where they're at. We're going to always begin and end with our primary assessment. You know, if the patient doesn't want you to take their vital signs, they don't want your blood pressure checked, they don't want your pulse checked, they don't want, you know, you to even touch them. Okay, that's fine by me. We can still assess pretty well their vital signs just by visual. I'm going to get a skin color and condition. I'm going to get a respiratory rate. I'm going to know that their airway is open, clear, and secure because they're either talking with me and we're having a grand old chat on our way to the CHA in Everett, or they're yelling and screaming obscenities at me because they don't want to go to the CHA in Everett. Either way, I'm happy because I can't fix their behavioral problem. I cannot fix their psychiatric crisis. All I can do is bring them to people who can and make sure that they remain a live, somewhat functioning human in the process. And that is a wrap. We have covered our behavioral emergencies. Anybody got any questions? I heard somebody sounded like they were about to say something. All right, if you guys are good, then I'm good too. I will see you all at 1 o'clock. Don't get stuck in the snowstorm on your way over here. Crazy weather out there today.
All right, thanks, Tom.
No problem. I'll talk to you guys soon.
Thanks, Tommy.
You got it.